So I'll be speaking on the first trimester screening for preeclampsia. And before I go into the lecture per se, I want all of you to imagine this situation. Here I am starting a lecture at 10 o'clock in the morning. 30 minutes from now, I would be finished with this lecture. And in this 30 minutes, somewhere in the world, 4 pregnant women would have lost their lives to preeclampsia. The morbidity and the mortality that comes along with for these children, and the kind of impact that this double hit is going to have on these families is also quite huge and unimaginable. Now, the scene is not too different in our country or in our state for that matter. I was just speaking to Piley sir before this, and you could see from the data of the confidential review of maternal deaths that hypertensive disorders in pregnancy is still the second most common reason for maternal deaths in our part of the world. Now, that notwithstanding, we've always spoken about diagnosing preeclampsia, treating preeclampsia in time, but not so much, or never so much, about screening and preventing preeclampsia. So when Ambuja madam asked me to speak about preeclampsia screening in the first trimester for this lecture, I asked myself this question as to why this is the scene. And I realized that the best way to answer this question would be to ask ourselves, our own colleagues, as to what they thought about preeclampsia screening in general. So which is what I did. I met up with a few of my colleagues who phoned personally and then asked them, what are your thoughts on preeclampsia screening? Got some very interesting responses. So I've handpicked 10 of these responses that I've got. And my answers or my comments to these responses would what would make up the rest of this lecture. So the first response I had was preeclampsia screening test. Is there even something like that? Well, there is certainly something like that. The Fetal Medicine Foundation has come up with what is today called as the first trimester multimodal screening for preeclampsia, which is a combination of maternal demography and certain biomarkers, as they're called. You put these into an algorithm and then derive the patient's individual risk for developing preeclampsia, just as you do with Down syndrome screening. Now, these biomarkers that I spoke about could be biophysical markers, like an ultrasound measurement, or it could be biochemical markers, like one of the hormones or proteins that you would test in a maternal blood serum sample. Now, the information that you get from these biomarkers are then put through an algorithm which is based on what is called as a competing risk approach, by the end of which, by applying Bayes' theorem, as it is called, you would get a personalized risk for preeclampsia in this mother at any desired gestation. Say, for example, you would say that the risk of Mrs. S developing preeclampsia at 32 weeks is 1 in so-and-so, 34 weeks is 1 in so-and-so, 37 weeks is 1 in so-and-so, and so on and so forth. Now, related in context or in relation to this context, the Fetal Medicine Foundation is very clear about 2 distinct phenotypes of preeclampsia, just as they say there are 2 distinct phenotypes to fetal growth restriction. Now, the first is what we call as preterm preeclampsia, as the term implies it's below 37 weeks of gestation. The other being term preeclampsia, when it happens beyond 37 weeks of gestation. Now, preterm preeclampsia has got a very, very strong association with defective placentation, defective trophoblastic invasion, and so on and so forth, and the cascade that follows from there on. Whereas the association of preterm preeclampsia with maternal risk factors is far less significant. So it's got more to do with abnormal placentation than the historical risk factors of diabetes, chronic hypertension, so on and so forth. Whereas on the other hand, term preeclampsia, the association with defective placentation is poor, which is why it manifested quite late in gestation, whereas the association with maternal risk factors is much, much more significant in this phenotype than in preterm preeclampsia. Now, when we talk about screening for preeclampsia, what we are concerned about is the preterm preeclampsia, simply because the morbidity is much, much more higher, and delivery is not as straightforward a decision as you would take with term preeclampsia. So preterm preeclampsia screening is where the focus of preeclampsia screening has always been on, and that is what the FMF algorithm also follows. So essentially, the first trimester multimodal screening for preeclampsia. I'll keep repeating this throughout the lecture so that you get familiarized with this concept. Entails a combination of maternal demography and certain biomarkers, and this will give you the risk for preeclampsia at a certain gestational age, at any gestational age for that matter, in a particular mother. So that's what the screening is all about. Now, a very easy parallel that you can draw and relate to is the multimodal screening that we do for Down syndrome. There again, you have maternal demographic factors, particularly the maternal age to start out with. You then add certain biophysical markers to the ultrasound markers like nuchal translucency, nasal bone, ductus venosus, tricuspid regurgitation, and so on. And you add a biochemical marker like beta HCG and PAPA, and you end up getting up to 90% detection rate for Down syndrome. Exactly a similar fashion that preeclampsia screening also follows. So that's about the first response. The second response that I got was, we've been following the ACOG and NICE recommendations of risk factor-based preeclampsia screening for so long. Now, why do you want us to shift to this new test now? Again, a very valid and genuine question. Indeed, we have been following historically the risk factor-based screening approach that has been proposed by NICE and ACOG at different times. Now, this is certainly better than no screening at all. So what we would do is to look at these risk factors from a historical perspective. You ask certain questions, leading questions to the mother. You identify if there are risk factors. We have one high risk factor and or two moderate risk factors. This mother would then be classified as at high risk for preeclampsia, and you would start her on prophylactic low-dose aspirin. Now, this was what we were following for quite some time. The problem with this, as I said, it is certainly better than not screening at all for preeclampsia, but from a screening perspective, the best detection rate that you can get with this sort of an approach is only around 39%, or a false positive rate of 10%, which means even if you do a history-based screening or a maternal demography-based screening, you're still going to miss out on more than half of all your preeclampsia cases who would indeed have benefited from aspirin had you picked them up in time. So this is a failure of the historical approach or history-based, risk factor-based approach from ACOG and NICE. Now, the reason this fails because is as we said before, we're trying to look for preterm preeclampsia here. That is the villain as far as preeclampsia is concerned. So preterm preeclampsia does not strongly correlate with maternal risk factors, which is why, as expected, a risk factor-based approach may not be the ideal screening tool for preterm preeclampsia, where the defect is mostly got to do with placentation, abnormal placentation, and not maternal risk factors. And therefore, research over the last 15 years has been trying to identify certain biomarkers of defective placentation, because that is what is going to help you predict preterm preeclampsia, which is what we want to predict, and not late or term preeclampsia. So this research has been going on for quite some time. They've looked at several markers over the decade and a half, and eventually they've narrowed down to three very important and very relevant biomarkers, the first of which is mean arterial blood pressure of the mother. The second is uterine artery pulsatility index in the mother, both of which are biophysical markers. And the third is a biochemical marker, which is serum placental growth factor. Now, these are the three biomarkers that have been found to be of significance when it comes to preeclampsia screening. Now, the reason these are significant is because we know now that the root cause of preterm preeclampsia is a defective trophoblastic invasion of the spiral arterioles. Therefore, there's poor remodeling of these spiral arterioles. This leads to a hyperperfused placenta from the maternal side. Hyperperfused placenta releases certain pro-inflammatory proteins into the mother's circulation, and with these proteins that mediate endothelial injury and vasospasm, which is the root cause of preeclampsia. And if you heard Reggie sir mention, Professor Baski and his team in St. George's have a different approach to preeclampsia. They believe that the origins of preeclampsia are not with the placenta but with the heart, and therefore the cardiac origins of preeclampsia also need to be considered if you're thinking about screening. Now, if you go back to the three biomarkers that I mentioned, uterine artery Doppler addresses this problem. The serum PLGF addresses pro-inflammatory proteins because that is one of the pro-inflammatory proteins that are released. And mean arterial blood pressure addresses the cardiovascular maladaptation that was thought to lead on to preeclampsia by some authors. Essentially, you're including these three as biomarkers, and obviously you're addressing the core issues that lead to the pathophysiology of severe preeclampsia, preterm preeclampsia, and therefore you would expect naturally that your screening would be much, much more effective than going by risk factor screening alone. So essentially, the first trimester multimodal screening for preeclampsia is a combination of maternal risk factors from history, mean arterial blood pressure in the mother, uterine artery pulsatility index as measured in Doppler in the mother, and placental growth factor. These two, of course, as I said, being the biophysical markers and PLGF being the biochemical marker. Now this, because you're looking at three markers apart from the demography, this is also being referred to as a triple test or the combined test. Now do not mistake this with the conventional triple test or the combined test that we use for Down syndrome screening. So you might rather call this as a preeclampsia triple test or the preeclampsia combined test, so there's no confusion that's there. Now, if you indeed manage to put all these four together, history, mean arterial pressure, uterine artery pulsatility index, and the placental growth factor into your algorithm, the detection rate for preterm preeclampsia jumps significantly from the 40% that we spoke about by the NICE guidelines to around 75% if you do this properly with proper calibration and validation from time to time. All this for a 10% false positive rate. Now, within the preterm preeclampsia subgroup, there are two subgroups. One of early preterm preeclampsia, which is preeclampsia before 34 weeks. And if that is what you're trying to screen for, then the detection rates are even much better at around 90%. So this is a quantum leap from the 39% that you saw with history-based screening, which is why the FMF keeps reiterating, all world bodies today, all women's health bodies today, keep reiterating that you seriously need to start thinking of preeclampsia screening by this multimodal screening platform. Now, if you still vouch by the NICE and KFOG guidelines, be aware of the fact that FIGO has come out with its latest recommendation, and this recommendation also unambiguously vouch for first trimester multimodal screening for preeclampsia and not history-based screening as we used to do before. Now, the third response I got is we've heard about the test all right, but do not really know how exactly to go about doing it. This is again a very honest statement, I would say. Now, this is what we refer to as lack of awareness. When you ask me about lack of awareness, again, there are two subtypes or phenotypes, as you could call it. One is a complete lack of awareness, where you know nothing about the subject. And the other is a lack of complete awareness, where you know something but really don't know how exactly it is done. Now, for both of these groups, the rest of my slides will try to answer and address this question. I'll take you through a quick walkthrough of exactly how, on the ground, the FMF preeclampsia screening test has to be practiced. Now, the screening design is very simple. It's very similar to what you would do with Down syndrome screening. There is a start of risk, which is called as the a priori risk. Now, this is derived from the maternal demographic factors here. You then measure the biomarkers, the MAP, the uterine artery PI, and the PLGF. You would get absolute values when you measure them. These absolute values do not carry a lot of meaning, so you would want to convert them into multiples of median, which will tell you exactly how deviated from normal these values are. These MOM values would have likelihood ratios, and these likelihood ratios are used to modify the a priori risk and eventually ends up giving you the estimated final risk for that individual for a certain gestation age. So this is how the screening works. And now we would take a look at these components of the preeclampsia screening multimodal screening model in a little more detail. First, of course, to start off is maternal demography. Now, there are a long list of questions that you need to ask the mother. I'm sure you cannot memorize this, so you would do well to get a checklist printed in your and pasted in your department, or you could have this on your mobile phone, whatever. You need to ask these leading questions, very specific questions that you need to ask to obtain a maternal demography risk score for the mother. Now, just by taking a proper history and calibrating her risk, you would end up picking up to around 45% of preeclampsia, which you would have missed had you not bothered to take history. Now, this is decent enough, but you're still missing out on more than half the cases of preeclampsia that are subsequently going to develop. So this is good as a starting point, but not great enough. The second component that we discussed about was mean arterial pressure. Now, when you say mean arterial pressure, it refers to diastolic pressure plus 1/3 of pulse pressure. Pulse pressure in turn being systolic minus diastolic pressure. Now, this is what is mean arterial pressure. It's not the mean of pressures measured on both hands. No, this is a specific entity which is called as mean arterial pressure. And there has been enough literature now that says that mean arterial pressure is a significantly better predictor of preeclampsia than either systolic or diastolic or both of them taken in combination, because mean arterial pressure better indicates perfusion to white organs, which is what is going to be affected in preeclampsia anyways. So mean arterial pressure is what we need to look for, and not systolic or diastolic blood pressures. Now, there's a very, very specified manner in which you need to measure the mean arterial pressure. You need to use validated automated devices, not sphygmomanometers. Make a good note of this. These devices are very easily available in the market. You can buy them, not very costly. It might cost you slightly more than your sphygmomanometer, but it's certainly within reach of all of us, I'm sure. Now, the woman, before taking her mean arterial pressure, has to be rested for at least 5 minutes. Arms have to be supported at the level of the heart, both arms. You would need a chair as the one that's shown in the picture, where the arms can be supported at the level of the chest. You would need different cup sizes to suit your patient. You would need a combination of small, normal, or large cups, depending on the mid-arm circumference of the lady. And of course, you need to measure blood pressure simultaneously in both arms. So you need 2 of these calibrated automated sphygmomanometers. And then you measure both these arms simultaneously, 2 measurements each, and then take average of 2 measurements. So you would need 4 measurements in all. So these 4 measurements, then you take the average, and then you calculate the mean arterial blood pressure from them. Now, this is the chair that we use in our setup. You can see the double arms in which the patient's arms can be rested at the level of the heart. Now, if you combine maternal demography with mean arterial pressure, your detection rate improves from 45% to 51%. So you're just about managing to capture half of your women who is trying to develop preterm preeclampsia. 61% of early preterm preeclampsia could also be detected by this method. Again, the risk cutoff is going to be 1 in 100 for all of these across the board. Detection rates are always mentioned for a 10% screen positive or false positive rate. The next biomarker that we spoke about is uterine artery pulsatility index at 11 to 13 weeks of gestation. Now, here again, there's a very specific method that has been mentioned. Always take this measurement by trans-abdominal ultrasound if you're going to use it in the risk screening algorithm, because all the nomograms and all the values that have been used hitherto for calculation of MOM values have been by trans-abdominal ultrasound. So even though you can measure uterine artery PI by transvaginal ultrasound, you would have to take a trans-abdominal reading if you have to use it in risk calculation. You need to identify uterine arteries as the first step. It's always taken in the sagittal section of the cervix. I'll show you a video of how it's done. Switch on color flow mapping. You fix the probe in the midline, and without moving the probe, you tilt the transducer to either side to get the uterine arteries on each side. Remember, 11, 13 weeks, the cervix is going to be very small. So if you move the probe, you're going to be completely out of plane. So you just need to tilt your probes slightly to left and right. You will get both of these uterine arteries on either side. You need to keep a sampling gate of around 2 millimeters to cover the whole vessel, and the angle of inclination has to be less than 30 degrees so that your value is not erroneous. And how do you identify it as indeed the uterine artery, not one of its branches like the arcuate or the basal, is by looking at the peak systolic velocity after you get the trace. Now, if your velocity is more than 60 centimeters per second, you can be sure that you measured the uterine artery and not one of its branches. And you take the mean PI of both sides, because sometimes the placenta could be off to one side, so the other side could show slightly increased resistance. But when you take the mean, it kind of evens out. So you need to take left and right, and then just divide it by 2. Now, this is not as complicated as measuring the mean arterial pressure. Now, again, there's a question that's always asked about why PI and not why RI. Now, PI is, of course, more stable than RI and could still be used when there is absent or reversed diastolic values, unlike RI, which would reach infinity when there's an absent diastolic flow. Now, again, PI is any day superior to uterine artery notching. Now, uterine artery notching is something that has to be completely done away with. Now, it is, of course, going to be abnormal when you have a patient who's going to develop preeclampsia, but it is quite subjective. The specificity is very low, and up to 50% of women could normally have uterine notches in the first trimester. It just tells you that your presentation, your trophoblastic invasion is not yet complete. And 70% of these women who show uterine artery notch in the first trimester, when you see them in the second trimester, the notch would have completely disappeared. So it's a very non-specific sign, whereas PI is much, much more objective, and that's why every guideline recommends that you use the uterine artery PI instead of the RI or the uterine artery notching. Now, this is a video that was borrowed from Sanish and taken it beautifully, so I didn't want to supplement it with any other video. So this is, as I said, you keep the probe in the midline vertically. This is where your cervix is going to come. And then you just to either side. You get the right uterine artery on this side and the left uterine artery on the other side. And this is how it would appear on, This is how it would appear on ultrasound. So that's the sagittal section of the uterus there, and the cervix here. You slightly tilt to one side, you get the uterine artery. Keep a sample gate of at least 2 milliliters, and you take a reading, and you could see that the velocity is more than 100 centimeters. More than 60 is definitely suggestive that this is indeed the uterine artery. And you look at the PI values. That's how it is done. Now, if you add uterine artery PI to maternal factors and mean arterial pressure, you would get a detection rate of up to around 70% for preterm preeclampsia. So with each biomarker that you're adding on, your detection rate is steadily on the increase. Now, the fourth marker we spoke about was placental growth factor, PLGF. Now, this is a pro-angiogenic factor that is released by the placenta, and it is quite vital in stimulating trophoblastic growth and angiogenesis in the placenta. So if you have lower values, that says this is something abnormal with the presentation, and these babies are at higher risk for developing preeclampsia. And remember, PLGF values become abnormal 9 to 11 weeks before the disease clinically manifests. But of course, this is not something that you can do on your own. You would need a very reliable, accredited lab to give you PLGF values, because remember, you're going to use all of these into an algorithm. So if your results are not validated, your risk prediction is going to go completely haywire. Now, if you add all of these four, is when you get detection rates of around 75% for preterm preeclampsia, 90% for early preterm or severe preeclampsia. As I said, across the board, the risk cutoff that we use is 1 in 100, and these cutoffs have been derived over the years by several statistical methods. So for a false positive rate of 10%, you can get up to 75% detection of preterm preeclampsia, as opposed to the 39 or 40% that you would get with the ACOG or NICE guideline for the same 10% false positive rate. So it goes without saying that this is definitely much more superior to history-based screening, if that is what we've been following all this while. Now, I've spoken about all the four components. Now, what you do is, how do you actually use this on the ground, in practice? As we said, the easiest thing to do would be to get these values and send these values off to the lab in a test request form. So the lab will do all the calculation for you and give you a printed report that would look somewhat like this. It will tell you the individualized estimated risk for preterm preeclampsia as 1 in some number. The other option that you have is to use calculators that are freely available online. And this is the one that is available from the FMF. You have one from the FIGO. You also have mobile apps that can calculate the preeclampsia screening risk. All that you need to do is to key in these values, the demographic values, the height, weight, etc., whatever demography that we spoke about, the biophysical and the biochemical measurements here. This value you will get from the lab, so you enter the MOM value here, and then you can press on calculate the risk. It will give you the individualized risk for that woman at different gestation ages. So this is how you need to apply. You need to have the calculator, or you need to have the mobile app, or simply enough send off all the results in a test request form to the lab, and the lab will give you a printed report. A lot easier than calculating it yourself. Now, the fourth response: what benefit will preeclampsia screening offer my patients? Again, a very pertinent question. Now, this is what the ASPRE trial, the mother of all preeclampsia trials, try to answer. Now, the ASPRE trial, for those of you not still familiar with it, was a prospective multi-center trial that looked at around 27,000 patients. There were two parts to the study. The first was, of course, to apply this combined preeclampsia screening multimodal algorithm to all women at around 11 to 13 plus 6 weeks, and try and identify this cohort of high-risk women from this based on the screening approach. Part 2, these high-risk women were then randomized to receiving either 150 milligram of aspirin or placebo to try and see if the effects of preeclampsia could be delayed or prevented. Now remember, the dose of 150 milligram per day, not 75 milligram, was used because aspirin resistance is quite high at 75 or 81 milligrams, as high as 30%. You would not get your desired benefits. Whereas if we use 150 milligram, the resistance comes down to around 5%. Also remember the rough dose of low-dose aspirin that's required to have a beneficial effect on the trophoblast is around 2.5 to 3 milligrams per kilograms of your. If your mother is 50 kilograms, you would need very simply 150 milligram, not 75 or 81 milligrams. That's the reason this trial used 150 milligram of aspirin per day and not 75. Now they said you have to start aspirin at 12 weeks because placentation is complete by around 16 weeks, and beyond that, because aspirin is believed to affect placentation, if you give it beyond 16 weeks, there is no benefit to giving aspirin at all. They said stop at
Vivek, sorry to interrupt. Another 5 minutes. You can,
yes, yeah,
5 minutes more.
Yeah. So they said stop at 36 weeks because there was a potential risk of hemorrhage in the unit, and they said give it at bedtime and not lunchtime because that is when the maximum benefit was observed. Now, what aspirin does is that it does not completely stop preeclampsia or prevent preeclampsia. What it does is it delays the onset of preeclampsia. So if preeclampsia was to develop at 24 weeks, aspirin will push it somewhere to 32 weeks. So all these early preeclampsia were taken out of the equation with aspirin and pushed all the preeclampsias towards later in gestation, which it gives you a much safer window to try and deliver these babies and save the mother. Now, this is exactly the same thing that's shown here. Aspirin delays the onset of preeclampsia from, say, 30 weeks or 24 weeks to 36 or 38 weeks and beyond. So it gives you that much more time for the baby's lungs to mature. You're much safer and happier delivering babies at 36 and 38 rather than at 28 and 32. Now, the benefit of aspirin, as expected, did not have much of a benefit on term preeclampsia because it does not alter placentation. And term preeclampsia is not related to abnormal placentation. But when we talk about preterm preeclampsia, there's a 62% reduction before 37 weeks, 82% reduction of preeclampsia before 34 weeks, and 89% reduction before 32 weeks. Now, this would, of course, depend on the compliance as well, which I will skip for want of time. Now, the fifth response, wasn't this test designed for Western women? Can we use it here in India? Well, of course, make no mistake about the fact that this test was very well validated in all the Asian countries, and including in Chennai in India, and Professor Suresh was was one of the principal investigators of the study. They've done extensive validation tests and have come up with very similar data as to what was obtained in the West. They've concluded that the FMF triple test is indeed much superior to KFOG and NICE recommendations. And not just in India and Asia, the test has been validated around the world, and everywhere the picture has been notified. Sixth response, I know uterine artery Doppler for all patients isn't that good enough. It is good, but certainly not good enough because your detection rates by just doing uterine artery Doppler in the first trimester is again less than what you would get by history-based screening alone. Around 48%. Who never used uterine artery Doppler as a standalone test, always use it combined into a multi-factorial screening model. If you are to use one of these two, it should be the mean arterial pressure rather than the uterine artery PI, because mean arterial pressure with maternal demography gives you better detection rates than demography with uterine artery PI. Ideally, you should use all of these together, but if you're not able to use these for some reason, then it should be mean arterial pressure and demography rather than uterine artery PI and demography. Seventh response, why should I bother about screening? I give 75 milligram aspirin to all my patients. Again, a very common rhetoric that you would hear. Now, let me give you 3 reasons why aspirin should not be prescribed universally. First, aspirin is not GEMS. It's not M&M. It is a drug. A drug is a drug any day. However safety data how much ever safety data you would have, aspirin still has some unwanted side effects, upper GI symptoms specifically, and a 5-fold increased risk of bleeding either in the upper GI tract or the intracranial region. Therefore, you would not want to push in aspirin unnecessarily to any woman for that matter. When you look at risk versus benefit for a low risk population, if you have to give it to everybody, the risks would outweigh the benefits. The second issue is compliance. Now, do you know how much people comply with folic acid? It's less than 50%. And for aspirin with all its side effects, it's going to be far lesser. And If at all people comply, it's going to be the ones who really don't need them, the affluent, the educated patients. Whereas preterm preeclampsia we're talking about is much, much more prevalent and more risky in the low socioeconomic strata, and it is very, very unlikely that these patients would have a good compliance if you start giving it to everybody. So that's why targeted therapy is a very important step to ensure compliance. And the third reason is about the numbers needed to treat. Now, preterm preeclampsia happens in 3 out of 1,000 women. So if you are to treat all these 1,000 women with aspirin, you would need to unnecessarily treat 997 women to prevent one preterm preeclampsia. Now, that's an ethical question that all of us need to ask ourselves whether we need to give everybody low dose aspirin in this context. Now, the eighth response, I do screening tests, but only for women with risk factors. Now, we've addressed this issue already. There's a question of selective versus universal screening. The problem is more than 60% of preeclampsia, preterm preeclampsia happens in the unsuspecting so-called low-risk groups. So that's why universal screening has to be practiced and not just focused on high-risk screening. Ninth response, we've not even started screening for Down syndrome, then why would we even think of preeclampsia screening? Now, if you've not started Down syndrome screening in this day and era, you are like a train that's running late by more than 20 hours. Because when preeclampsia screening came to India, this is how our Prime Minister looked. This was the Indian cricket team celebrating a famous victory, test victory against Australia. And the battle between geared and gearless scooters had just begun. So if you have not practiced, if you've not started screening for Down syndrome now, the only way you can derive solace from that is the fact that you were 20 years younger than you actually are. Apart from that, I see no reason why you should not do Down syndrome screening today. If you've not started it, start it now. And to add one step to that, if you compare preeclampsia screening with Down syndrome screening, preeclampsia screening is much more an obvious choice because the prevalence of preeclampsia is much, much higher than the prevalence of Down syndrome. Preeclampsia affects both the fetus and the mother, not just the fetus. And here you have an intervention, whereas the only intervention that you can think of Down syndrome screening is termination. So preeclampsia screening in that regard makes much, much more sense than Down syndrome screening. So you're not doing Down syndrome screening is not an excuse for not offering preeclampsia. In my honest opinion, you should do both of these things. The last response, Down syndrome screening itself is expensive. So this would be an additional burden on my patients. Not really. If your patient can afford 1,600 rupees for Down syndrome screening, I'm sure she can afford another 400 to try and find out the deadly disease that is going to happen in the patient or not. So it's just a matter of 400 rupees in most labs today. Now this is the data from Perkin Elmer, which is one of the accredited labs for preeclampsia screening. Down syndrome screening charged at 1,600, preeclampsia screening at 2,000. So just an increment of 400 rupees. I'm sure this is nothing when you've been doing NIPTs left, right, and center. And NIPT costs anywhere between 8,000 to 18,000. So rather than doing NIPT for all your patients who really do not need them, I would strongly advise or recommend that you go for preeclampsia on top of Down screening. So do these together. If you do both these together, it's just 2,000 rupees. It's not that this is separate and this is separate. So a package of preeclampsia plus Down syndrome screening in a reputed lab is only 2,000 rupees. This is compared to 8 to 18,000 for NIPT. Now, again, cost effectiveness is a completely different paradigm altogether. You need to really be looking at the number of preeclampsia cases that you're going to prevent. The health economics is completely different. This is a study from Canada that told us that the benefits
Vivek,
last slide. The benefits of preeclampsia screening is that it saved around 14.3 million Canadian dollars a year, which is the equivalent of 80 crore Indian rupees. So you cannot say that this is not cost effective. It certainly is in the larger picture. And if you're not thinking it's still cost effective, what you can do is to not opt for everything together because the hormones might push up the cost. You can still use history, uterine artery pressure, and mean arterial pressure and uterine artery PI. But remember, the more compromises you make, the more factors you take out of this algorithm, the lesser your detection rates are going to come. So ideally use all of these as a stopgap arrangement. You might step down or compromise on one of a few of these. So take home messages. Preeclampsia screening is here to stay and should be offered universally. Remember that the FMF multimodal screening is the best option. It should be offered wherever possible. Screening performance will be reduced when screening does not include all the elements of the test. And if PLGF and uterine artery PI are not available, is when you would just use maternal risk factors. In that case, always remember to add on mean arterial pressure. Use the calculators, use freely available calculators in the mobile app, but please start doing it from today onwards. In a limited resource setting, if none of these is possible, you can use the contingent screening model. You screen every mother with maternal factors and mean artery pressure. Use the calculator to get your individual risk. And for those who come up as high risk with maternal factors and mean artery pressure, you can also add on PLGF and uterine outlet PI as contingent markers, like you would do with Indian screening for Down syndrome. Thank you, and sorry if I haven't seen the time by 2 minutes.